Okay, and let's see, Alexander.
Yes, no,
First
maybe.
is yours, not
Okay.
maybe. Okay,
Okay,
let's
let's
start.
go. Okay, a person fainted while working in the summer heat for a long time. Complaints: thirst, dry mouth, weakness, oliguria. Physical examination: decreased skin turgor, blood pressure 110 to 70. Laboratory parameters: 100. Well, that's hypernatremia, and 5 millimolar potassium. Hematocrit
Mm -hmm.
0.45, and HCB concentration. HCB is 160 gram per liter, and MCV 400, whatever FL means.
160 gram per liter.
No,
The
I mean
hemoglobin.
70 FL dot.
That's femtoliter. That's
Oh,
the
that's
size
femtoliters.
of
Okay.
the red blood cells. Okay, let's summarize
Okay.
these things. What will happen?
Well, I mean, the complaints, thirst, dry, etc. This is typical for dehydration.
Okay.
So that's that. Decreased blood pressure, probably because of the excessive fluid loss.
Okay, so the hypovolemia, that's be the
Hypovolemia,
results of
yes.
hypovolemia.
And since water is lost, technically water is lost quicker than sodium, we do have a hypernatremia, relatively speaking.
Okay, wait a little bit. When we sweat,
Yeah.
usually we are losing a hyponatremic solution. So we are losing more water than
Yes.
salt. This is why we do develop a hypernatremic hypovolemia. Do you know what the concentration of the sodium in the sweat?
No, not on top of my head.
About 30 to 40 millimole per liter. So if
30
you
to 40.
compare to the
Okay.
normal, the serum sodium concentration, that's about 5 times less or 4 to 5 times less. So this is why we are losing hyponatremic solution and we are losing almost water. So what will happen when we are losing water? This water loss is distributed into the all compartments. So we do have the all water content of the body, including the intracellular spaces and the extracellular spaces as well. So both. This is why it's very important one to know that depending on what kind of fluid you lost, this is what you should replace it. Okay.
Right.
Now, so in our case, what will happen? We do have a hypernatremic hypovolemia. So it meaning we do have a hyperosmolarity inside the blood.
Right.
Okay. Now let's see the parameters. First of all, the potassium is not increases too much. The sodium,
No.
yes, it did. So this is why we know that this patient has an increased osmotic pressure. However, nor so potassium or hemoglobin. Hemoglobin increased a little bit, and hematocrit doesn't change too much.
But the MCV is decreased because of
Okay,
the increased osmolarity. So the
yeah,
red blood
because
cells lose water.
exactly because the water comes out from, let's see, the red blood cells. This is why you do have a shrinking of the red blood cells. So this situation was going to develop. So what we are going to do with this patient, let's see. That's an acute situation because if you had a chronic, let's see, water loss, a chronic hyponatremic hypovolemia, you cannot infuse back the old water, so you cannot normalize exactly immediately back to the osmotic milieu, because it's meaning that the intracellular spaces, usually they are producing some osmotically active particles to retain the water. Now, if you normalize the osmolarity in the serum, that meaning you can cause brain edema very easily because you do have an increased osmotic activity inside the spaces, so intracellularly. This is why you have to do it about 2/3 the first day and 1/3 the next day. This is how they work it. The opposite will happen if you overload it or the patient has hypervolemia with hyponatremia. The excess water should not be, let's see, urinated out immediately by using some diuretics. Again, 2/3 one day and 1/3 another day, because the opposite can happen. All right, this is how the body can, let's see, used to these situations. Now, what will we do with this patient?
Did you just say? Like water, like fluid replacement?
Okay, let's see.
I mean, you should be giving an electrolyte solution, right? Like you
okay,
need
let's it's okay. Let's see.
hypotonic fluid.
First of all, if this patient is cautious, what you have to do, give water, let's see, mineral water to the patient, and that's it,
Right.
orally. However, if the patient lost consciousness, you cannot give orally water. So what you have to do, IV
Intravenously?
infusion, exactly. Now, what kind of fluid you are going to infuse to this patient who lost mostly water, not sodium?
Mm.
That's very
Well, he did
interesting.
lose. What he did lose, what hypotonic fluid, right? So
Exactly,
that should be replaced.
Yeah, it's true. Let's see, isoosmotic but hyponatremic solution you should infuse. Yes, this is what you are saying. That's a trick. Okay. No,
it doesn't sound great.
Yeah, it sounds tricky. Yes, it's true. This is what you should replace the patient. However, what kind of substance you can use to adjust the osmolality of the infusion beside of the sodium?
You can use glucose, I guess.
Exactly. Glucose solution. So, for example, 9-gram glucose solution or 9% glucose solution is isotonic one. Exactly. However, the problem with this, you can give a free water to the patient by giving glucose solution. However, what is the problem? If you add only free water, so the glucose solution in this patient, this fluid, what you, let's say, infuse the patient, is distributed into the whole compartment, meaning that only 10% goes to the intravascular spaces. Because if you compare the whole fluid compartment, let's say the blood takes about 10%. Now, this is why, because what the doctor does, first they are giving saline to the patient or Ringer lactate solution that has more sodium in it. That's an extracellular fluid. However, if you infuse extracellular fluid to the patient, 1/3 immediately goes into the blood. And the body is very sensitive to the volume, the blood volume. This is what you have to replace first. And okay, after giving, for example, 2 liters of saline solution, now you can dilute out the saline with glucose and making hyponatremic solution, but isotonic solution. Did you follow me?
Yeah. So first you need to replace the blood volume. That's why you give the saline solution first.
Exactly. Because from the extracellular space, 1/3 is the intravascular space.
Yeah. So I don't quite understand why why does if you give the glucose solution immediately, why only 10% is being retained in blood, but if you give a saline solution, 1/3 is retained. I didn't quite follow there.
Okay, I'm going to show you the graph that I projected, okay, at the beginning. Let's see this. This is very important one. Okay, can you see? Everybody can see it? Okay, good. So this is the total water compartment, okay? 2/3 located intravascularly, so that intracellularly, and 1/3 goes to the extracellular space. All right? This is how the water is distributed. What is the difference between the blood and the interstitial fluid? Well, the protein. You do have albumin in the blood, you don't have albumin in the interstitium, but the ions and everything the same. Okay? Now, this is the extracellular space. If you look at this one, the water compartment, 1/3 the blood, 2/3 in the interstitium. This is how the extracellular space is distributed. All right? Now, if you give extracellular fluid, only this fluid goes into this place. They are not going to go into intracellularly because what is the difference between intracellular and extracellular spaces? The sodium potassium ion, the membrane potential is different one. Completely. So this is why the water, or let's see, the extracellular water doesn't go immediately to the intracellular spaces.
Oh, right. So you essentially give the fluid replacement. The first part is essentially the same
Exactly.
concentration of
Yes, that's it.
electrolytes as the
Yes.
extracellular. That's
Yeah.
okay. Now
So
I understand.
if you gave, for example, blood, this blood goes only into the intravascular spaces. That's it. Okay. If you could use interstitial fluid or whatever, that relatively goes into both space in the extracellular spaces. So this is why it's going into the blood as well. Because what the difference between these two? Only the protein. Because you don't have any, let's say you do, but not too much. For example, there's no albumin in the interstitium, but we do have albumin, for example, in the blood. That's oncotic pressure, what is making the difference or the ratio of the volume. It's equilibrated. Okay.
Yeah.
All right. And if you give water, free water, that's going to go to the whole compartment. And this is why, as you see here, that's only 11% of the whole compartment. I said 10%, but 11%, 10%, about the same. Okay.
Okay.
All right. Anybody has any question?
Wait, one thing, just to clarify, if we just give water and the distribution will follow like equally across all compartments,
Exactly.
the danger there is that we develop, like, for example, brain edema, right? So
No.
or
In
what's
acute
the
situation, there is no chance to
okay.
develop brain edema. If the patient lost water rapidly, there's no chance to develop any kind of, let's see, production of the osmotically active particle intracellularly.
Right.
It takes days to develop. However, if you are wandering in, for example, the desert and you are sweating as a hell for days, now, yes, that you are going to develop. So the brain wants to maintain the normal volume. How they can maintain it with a, let's see, hyperosmotic milieu, if the osmolarity intracellularly increases and doesn't let the water go out.
Okay, so what's the problem then with just giving water and let the water be distributed and then readjusted internally?
Now, the problem is that if, for example, if the patient lost a lot of volume, let's see, blood volume as well, okay? You have to replace the blood volume first to maintain the normal perfusion.
Okay, I see. Yeah, okay.
And if you cannot maintain the perfusion, that could be the problem. Okay, let's see. If you want, for example, you lost 1 liter of water, okay? 1 liter of water from the blood. Now that's too much. So this way the patient is in shock. Now what you do, okay? You want to replace, let's see, the blood volume by giving only hyponatremic solution. So you have to infuse the patient with 6 liters of free water to bring back the normal blood volume. Now that's too much. First of all, the heart won't tolerate it. Plus, it's very slow process when everything goes back because immediately the water goes everywhere. So this is why when you start, let's see, infusing the patient, use first extracellular fluid. And after, when let's see, the blood volume is, let's see, close to normal, that maintaining the normal peripheral perfusion, okay, you can adjust the water content of the body.
Okay, yeah, I understand now. Thank you.
All right.
Could you repeat again why you said glucose also with the water?
Because let's say glucose has its osmotic activity. So if you dissolve the glucose in fluid, for example, 9 grams per liter, that makes it isotonic. So you can infuse to the patient, all right, without having any kind of hemolysis,
So why not continue with isosmotic with sodium potassium, for example?
No. This is because the patient mostly lost water. If you continue
Okay.
loading the
But then
body
it
with
will.
sodium and potassium, the patient is going to develop a hypernatremia.
But the
Because you
glucose
do
will also move
yes,
to the intracellular spaces.
glucose, yes, but the glucose be uptaken and the water stays there and water distributed immediately. Hmm?
So it's just slower process. I mean, we just...
Yes, a slower process. Exactly. That's a much slower process. And you should use much more water, much more fluid. So you have a limitation what the heart can tolerate. You cannot load as much as, let's see, the blood volume. That's too much. Okay, so this is why first you have to normalize the perfusion, and after you can adjust the normal sodium and water balance. All right. More or less. We will get back to this point, don't worry. Okay, anything, the next one, Brian?
Yes, I'm here.
Okay, let's see.
Okay, so an elderly person gets sick while enjoying himself on Oktoberfest. He complains of headache, muscle cramps, is disoriented. He has drunk 4 liters of beer during the past 2 hours. The physical examination shows alcohol in the breath, increased plantar extensor reflex. Okay, and let's look at the lab parameters. So the blood pressure, if you look, it's 180 over 100. And so we know that this is a bit higher than normal. We look at the sodium levels is 126. So the normal is 135 to 145. So we know that sodium is kind of lower than it should be. The potassium.
So hyponatremia. Clear.
Yes,
hyponatremia. Okay.
So I'm thinking this is maybe like a maybe the opposite of what we saw the previous one. Maybe hyponatremic hypervolemia.
All right. Yes.
So and then the potassium level is
okay.
Normal. Yeah, and the
MCV is increased because normally about 80, 90 femtoliter. Hematocrit a little bit decreased, not too much, but it's decreased for a man. It should not be this. It's about 0.4, 0.45. Creatinine is increased. Urea is increased. And the urine density is okay. It's normal. And the urine, let's see, sodium. The urine sodium is 20 millimole per liter. So relatively, it's we are losing sodium. This is what it meant. Now let's see. First of all, let's go back to this patient drinks a lot. Drinks about 4 liter beer per 2 hours. How much beer you can drink per hour? You can drink water if you wish.
I mean, I think
So how much water the kidney can excrete?
500?
Nope.
250 milliliters?
No, more, much more.
1 liter?
1 liter, 1.2 liters or something per hour. So it means within 2 hours, you can drink about 2 liters or almost 2.5 liters without having any kind of water retention. So you won't suffer of water intoxication. However, this patient, first of all, drank too much. And the beer is a hyponatremic solution, so close to water. And this means the patient developed a hyponatremic hypervolemia. And because the osmolarity decreased, this is why the water went intracellularly as well. This is what you can see in MCV, but not only there, but in the brain. So this patient, due to the headache, muscle cramps, this is what somebody asked. I don't know who asked it. Maybe Itai. Did you ask it? The muscle cramps.
Yes, I did.
Okay, so this way, and especially increased plantar extensor reflex, that's a Babinski sign. That's a sign of brain edema, or let's see the herniation of the small brain. Now, so this edema, Now, why this patient developed this water intoxication or hyponatremic hypervolemia? First of all, he loaded the body with this water that the kidney could not excrete. Plus, what the problem with this patient? Look at the creatinine level. This patient diluted the blood, but the creatinine is still high, meaning this patient had some kidney problem. So these patients suffering of a chronic kidney diseases. So one thing that the creatinine should be much higher than this one because this creatinine is decreased by this dilution. And another thing, in the last time we discussed what should be the density of the urine. Normally the density is ranging from 1005 to 1036. Depending on how much water you had. If you had too much water load, the urine osmolarity should be about 30 milliosmol or so. In density, it means about 1005. So that should mean that we're producing diluted urine. The opposite, if you cannot access water, the more concentrated urine produced, so about 1035, 1036. However, this patient looks like cannot dilute because you expect to have a much lighter urine, about closer to 1. So it meaning the patient should urinate water, almost pure water. But because the patient cannot adjust the osmolarity of the urine, this is what we said, this is asteinuria. And that's another sign of the chronic kidney diseases. So this patient had a problem, first of all, load too much beer, water, plus the kidney is already affected as by the chronic kidney diseases. And this is why the patient cannot excrete the free water. So you cannot adjust, let's say, the osmolarity of the body. All right. And this is why this patient developed a hyponatremic hypervolemia and biliary edema. Now, what we should do with this patient?
Maybe we could give IV.
What is the biggest problem right now?
It's because we have the water poisoning.
Yeah, the brain edema. The brain edema is the biggest problem. How can we decrease, let's see, or how can we get the water out from the neurons, the neuronal cells? By giving mannitol and causes osmotic diuresis. So this is why, first of all, you have to infuse the patient with mannitol solution. And after you can use, for example, diuretics as well, if the kidney can, let's see, make let's say, water excretion. If not, because this kidney is already affected, you can use hemodialysis. All right. So that's the biggest problem in this patient right now, that this patient has brain edema. To solve this problem, mannitol solution, diuretics, or if it's needed, hemodialysis. Okay, but this patient has chronic kidney failure as well, can be seen based on the creatinine and the urea level and the density, okay, because cannot adjust the osmolarity of the urine.
Yes, okay.
Clear?
Yeah.
And for everybody? More or less?
Fair.
Okay, let's see the third one, Istvan.
Okay. An elderly woman has been on Nsaid treatment for a long time because of her rheumatoid arthritis. She got very weak after having an acute diarrhea. She feels too dizzy and needs to sit down. Physical examination, decreased skin turgor, blood pressure in the supine position, 120/80, standing 90/55, so quite low. Laboratory parameters, serum sodium, 116 millimoles per liter, so quite hyponatremic. Potassium, 6.2, so
yes, so it's high. Okay.
Hematocrit is 0.48, which is also high for women.
Okay.
Serum creatinine, 180 micromolar per liter. Serum urea, 18 millimolar per liter. Urine sodium is 50 millimoles per liter.
Okay, good. Now let's go step by step. So this patient, an elderly patient, was taking Nsaid. What is the function of Nsaid?
It's a cyclooxygenase inhibitor.
Okay, so it's inhibiting the inflammation and pain killer. Okay, now, and she did not have any problems so far. However, in the, let's see, lately, she had diarrhea. And now, due to the diarrhea, she developed a let's see, a orthostatic hypotension. This was the first one, okay? Plus hypovolemia because her skin turgor decreased as well. And when we looked at the parameters, this patient had a hyponatremic hypovolemia. Hyponatremic hypovolemia. Okay. And kidney problem because the creatinine increased and the urea increased and the kidney losing sodium. So it's meaning that the kidney cannot retain the sodium, all right? So that could be the problem that caused the hypovolemia with hyponatremia. Now let's see what is the function of the prostaglandins to maintain the normal kidney function. Basically, normally nothing. However, if the patient develops hypovolemia for any reason, edema or water loss or sweating or diarrhea or vomiting or anything, that meaning that decreased blood volume will have a decreased kidney circulation. So it will decrease the blood flow to the kidney. However, the kidney wants to maintain the normal perfusion, the blood perfusion. How? Relatively by increasing the prostaglandin. Yes, but this is due to the prostaglandin release. First of all, there are two prostaglandins that are important to regulate the kidney function. That's one is a PGI2, another one is a PGE2. Now, PGI2 is responsible to release renin. So that's going to release renin and angiotensin-aldosterone system. The other one, to maintain the normal tubular circulation, PGE2 as a vasodilator can work. So what will happen if you are knocking out? First of all, the patient can develop a tubular necrosis, plus it can lose sodium because the kidney cannot retain sodium nor water. And this is called analgesic nephropathy. Okay, this is the analgesic nephropathy. So in those patients who is taking Nsaid, we have to be very careful about when the patient has some kind of volume changes due to edema, for example, heart failure or protein loss or diarrhea or anything.
Because is prevention, sorry, question, is prevention just stopping the Nsaids or is there another medication?
No, yes. What is the problem right now? First of all, the biggest problem right now, the patient has hypovolemia. This is one. Plus, the patient has hyperkalemia. These two things. Hyperkalemia can cause arrhythmia. So that's dangerous. That's very, very dangerous. Plus, the hypovolemia causes peripheral circulatory disorders, shock. So you have to replace, first of all, you have to stop giving the Nsaid, but you have to normalize, let's say, the blood volume. This is one thing. So infusion should be given to this patient. You can have saline, for example. Plus, to antagonize the potassium effect, you should use, for example, calcium glucuronate. Calcium glucuronate that is going to blunt, let's see, the development of arrhythmia of the heart, is going to close, let's see, the channels of the sodium, so the membrane potential should be altered, all right? And after, if the potassium is still high, you can use glucose and insulin. This is how they are treating hyperkalemia. Because if you use insulin, insulin activates sodium potassium ATPase, and that's going to restore the potassium intracellularly. Okay?
Okay, got it.
So this is very importantly that you have to be aware that the patient who takes Nsaid can develop analgesic nephropathy, especially in those conditions when they have hypovolemia.
Analgesic nephropathy and response hypovolemia. Got it.
Yes, that's it. Okay.
Thank you.
All
Sorry,
right.
could you please repeat what you said about the prostaglandins, the PGE2 and PGI2? I did not catch that.
Okay, now there are two major effects of the disease prostaglandins. One, that's maintaining the tubular circulation, the vasorectal circulation. This is one. And another one, this is prostaglandin induces renin release. So this is going to mediate the macular densa to secrete renin. All right, so that's forcing the macular densa to excrete more renin, and the consequence be the aldosterone. And if you are knocking out the bot,
because the NSAIDs, they inhibit like the whole COX pathway, and that's why you can't have prostaglandin secretion. That's why the whole thing gets like busted up.
And these kind of prostaglandins, this COX doesn't depend only the COX-1, that's COX-2 as well. So this is why the specific COX-2 inhibitor will have the same kind of kidney effect. All right.
Okay, thank you.
Let's see the next question. That's be the easy one, Brian. That's a stupid question.
Yeah.
But you are going to overcomplicate for sure. Everybody is going to do it. Now let's see. Tell me.
So how will the following laboratory values be changed in a protracted, untreated diabetic ketoacidotic coma before treatment?
Okay, so what will happen when you do have an untreated diabetic ketoacidotic coma? The patient has hyperglycemia plus acidemia. That's it. So what will happen? Due to increased glucose, has osmotic diuresis. Period. Next one. When we do have ketoacidosis, we do have a hydrogen ion elevation. Yes, this is what we know. Now let's see how the total potassium of the body is going to change, how the total sodium of the body changed, and how the total water of the body changed. Let's start with the water. Osmotic diuresis?
So the water will be lost?
Exactly. So the total body water will decrease due to osmotic diuresis. Period. All right, good. Let's see what will happen with the total sodium of the body.
You would also expect the sodium to be lost because of the osmotic diuresis?
Not because osmotic diuresis, because the urine always contains ions.
Okay.
All right, yes, this is the total sodium. Now, what about the total potassium of the body? Now here that you start to overthink a little bit. Because what will happen when we do have too much proton? When we have too much proton exchange by potassium, meaning that acidemia accompanied with hyperkalemia. All right? So the serum potassium concentration will increase. But what about the total potassium? This will decrease as well. Okay, think untreated. If you go to the toilet and start pissing, all right, that's it. And I'm asking you, how your total body water changed? Decreased. How your total sodium changed? Decreased. How your total potassium of the body changed? Decreased. As long as I'm not replacing the water, sodium, and potassium, I lost it. If I split, I do the same. This is why they said untreated. Okay. So this is why it's a stupid question, because if you losing sweat or urine or anything, you are losing ions. So your total potassium, sodium, chloride, and everything decreased. That's another question, but it's not asking you how, let's see here is asking, does the serum potassium concentration change in parallel with the total potassium amount of the body? No, because just I explained, the potassium concentration of the serum increases, while the total potassium decreased. Yes?
Yeah.
Now, how do you think the appropriate treatment will change the serum potassium concentration? How we are going to treat the diabetic ketoacidotic patient? Fluid replacement, okay?
Yeah.
Plus insulin and fluid. What will happen? If you give insulin activates sodium potassium ATPase. So what will happen? The serum potassium concentration, serum glucose concentration will decrease. And you have to watch how the potassium is changing because it can cause hypokalemia. Later on, possible, you have to infuse potassium as well, not only sodium to this patient. Do you remember in the first semester when we had this question? Long time ago.
I don't remember it, no.
It's okay, it will come back. All right. Everybody understood?
So you give insulin and water?
No. First I give fluid.
Okay, fluid, insulin.
Then and after insulin into the fluid. So first you have to start to restore the circulating volume. This is why you are using saline or Ringer lactate solution. About 3 liter Ringer lactate solution immediately. And after continue with an insulin mini pump and the same kind of solution. But very, very important, first you have to replace the fluid. The perfusion is the most important of the body.
And then you need to monitor potassium regularly. And maybe...
Exactly. All right. And after, depending on how the potassium change, because usually insulin decreases the potassium concentration, you have to give potassium to the patient as well. All right. Good. All right, let's see. Okay. Let's see, Chanju.
Hello.
Hi. It's your turn.
An elderly man gets chemotherapy for his chronic lymphoid leukemia. He complains of intermittent palpitation and being disorientated. Blood pressure is quite low, 90 to 60. Serum low end, 135. Serum potassium high, 8.2. Hematocrit 0.28. I think that's
okay.
That's pretty low.
No, what do you think?
Let's see. Chemotherapy. Okay, that's okay. That could kill a lot of cells.
Yes.
That could explain why there's lots of potassium.
Exactly. So this patient had hyperkalemia. Hyperkalemia induced heart arrhythmia, so cardiac arrhythmia. This is why the palpitation, this is why the blood pressure decreased, okay? All right. And the hematocrit is not due to this one. The hematocrit is due to the chronic lymphoid leukemia, because we will learn it later on. We are going to start treating the patient with CLL if the patient has some effect of the bone marrow, for example, infiltration or lymphatic node enlargement or a huge number of lymphocytes. And when you do have this chemotherapy, you have to be very careful about the released potassium. So very easily, the patient can develop hyperkalemia. And what will be the effect of the hyperkalemia on the ECG?
You have a S wave, like a lot, like what's not S wave? What's like the what's that shape?
No, it's not that one. Not that one. That's hypokalemia is a U wave.
Okay.
No.
U wave. Oh yeah, U wave.
We do have flattening of the P wave increases the T wave, tall T wave, widening of the QRS complex, okay? And if you have a severe one, no P wave, you do have a very wide QRS and a very tall T wave. Looks like the patient has looks like a ventricular flutter, but it meaning that if one is the QRS and other one is a T wave.
So it's a flattening of P wave and widening of the QRS complex?
Tall T wave. Okay, tall
tall
T. That's a very important. After P reduced and QRS widens. Long time ago, you had this ECG. Okay, so what is our goal right now? The treating hyperkalemia. What we have to do? Giving insulin and glucose solution. Because if you give insulin, insulin is going to move the glucose intracellularly. So if you are not using glucose, that can cause hypoglycemia to the patient. This is why is a glucose solution together with insulin is going to reduce the potassium concentration. And as said before, to normalize or let's see decrease the arrhythmias, you use calcium chloride or calcium glucuronate to blunt, let's see, the activation or the excitability of the cardiac myocytes, all right? And another thing, if it's a potassium is over 8, that's immediately you should send the patient to hemodialysis. But meanwhile, you have to use insulin, glucose, and calcium glucuronate, all right? It was included into this little presentation. Can't you?
Thank you. Thank you.
Okay. Yes, let's see. Now, who has this one? Claire.
Yes.
A lady, finally. Okay.
A woman gets hospitalized after having broken several of her bones in a car accident. Blood pressure 80/50, heart rate 130 per minute. The patient develops oliguria after being stabilized. Laboratory parameters of 1 day later, sodium 150 millimolar per liter, so that's high. Potassium 7.2, creatinine 250 micromolar per liter, urea 18.8,
so and high, okay.
Yes, high, and hematocrit 0.33, which is low. And urine amount 200 milliliters.
So this looks like oliguria. They say that if it's per day, it's anuria, but in this patient, it's oliguria. Okay. So what is the problem right here? This patient had a car accident that could cause, for example, blood loss. So it's caused hypovolemia. And they normalized it because they gave back, let's see, the blood or everything. However, this patient developed oliguria, meaning that this patient developed kidney problem, acute kidney failure, due to the hypoxia, because the perfusion of the kidney decreased when we lost a lot of fluid. This is what will happening in a shock situation. Circulatory shock, this was the previous semester, okay? So if you are locking out the kidney from the circulation, that's relatively the thick ascending segment can be damaged and can develop an acute kidney failure. What could be the sign of acute kidney failure? Decrease of the urine, so the decreased GFR, decreased urine volume, elevation of creatinine, elevation of the urea, and elevation of the potassium.
Yes.
Okay. And the hematocrit is due to the patient lost a lot of blood. Yes. So what emergency treatment is necessary right here? Again, which one?
Hemodialysis.
Exactly. You can send the patient to hemodialysis, but to reduce the sodium potassium to avoid the arrhythmia or ventricular fibrillation, again, you losing calcium glucuronate, you are using glucose solution plus insulin, very important. All right, so the first things, if somebody has hyperkalemia and the potassium concentration get close to 7 or 8 immediately, because any time the patient can develop ventricular fibrillation and can die. Very, very important. So here we have to reduce the potassium, first of all, by giving the patient, let's say, calcium glucuronate. That calcium glucuronate stabilizes the membrane of the cardiomyocyte. Plus, you can use insulin and glucose while the patient is taken to the dialysis. And after, you should keep the patient on a hemodialysis for a while. And possible the kidney regaining, let's say, their function, and after maybe 1 week or 2 weeks or so, they can leave, or she needs kidney transplantation.
What about the hematocrit? You won't give her a blood transfusion?
Yes, you can use less transfusion as well. You can use transfusion, but this is the least problem right now.
Okay.
The biggest problem, this is the potassium. All right, that's the biggest one in this situation.
Okay.
All right. So these were the questions, and I'm going to check the link, and I'm going to, let's see, I don't know, because some